Hi everyone, this is a video lecture for HKIN 466, Clinical Exercise Physiology at St. Francis Xavier University. In this section, when we left class last time, we had identified that both improving cardiorespiratory fitness and increasing physical activity tended to reduce mortality risk, but that fitness seemed to have more of an impact than physical activity. A lot of these results have been generated in men. We have a hint from the first ACLS study that there's a benefit in women as well, but we want to get a better sense of whether it happens, whether this effect is robust in women, as robust as it is in men. The good news is that there's a lot of work on this subject, and rather than trying to present all of it here, I thought I would just briefly summarize a review paper for you, which effectively looked at the changes in women of physical activity and all-cause mortality. This is a pretty homogeneous study, so from a number of different countries covering a number of different clinical trials over a wide range of years. And you'll notice perhaps that a few of these authors are familiar. Paffenbarger and Lee are individuals that we've either seen or will see in the papers that we discuss next class. They did a lot of work with the Harvard alumni study that related physical activity, a longitudinal observational study that related physical activity to mortality. So these are big names that we'll probably see regularly and that you can look up if you want further information. So is physical activity as effective in reducing all-cause mortality in women? The picture kind of gives it away. 32 of 38 studies report a significant effect of physical activity on reducing mortality, and how much physical activity is required is right on with the guideline for men. About 1,000 kcal per week is sufficient to avoid premature mortality. What we'll see later on is how this works in young and old, but we'll see it in men. It's good to know here that this effect persists in young and old women, but we don't really know how the ingredients of exercise affect this trend. We don't know for sure if modifying the intensity or the duration has a more potent or a less potent effect, and that could be why there's some variability. The threshold of 1,000 kcal per week is the general consensus, but some papers said that less was enough or that more was required. And it could just be that the exercise is not standard between these studies, that there is such a difference in the threshold, the sufficient level of physical activity to avoid premature mortality. However, general agreement, and it's a nice easy number to remember, plus it's the same guideline as we have for men, so it makes our jobs a lot easier moving forward. So it's good for women, it's good for men, but we've looked so far at epidemiological studies, observations of a person at this fitness level is this percent likely to die, but what happens if a person changes their fitness? What happens if they become more or less fit over time? Does that impact their likelihood of dying, or is it somehow pre-programmed in? What better place to go to initially than to the ACLS, the Aerobic Center Longitudinal Study? Tons of data being collected here. This is a 5-year follow-up over the early years of the study, 79 to 89, and only 10,000 men. Only 10,000 men in the study. Such a small sample size. Fewer than we've seen in other versions of the ACLS, just because it's probably early on in the study, and it could be that some individuals might not have made it to the 5-year follow-up in the other groups. So only 10,000 men in this study. Again, fitness here is by graded exercise test time, and then that time correlates with a maximal metabolic rate, and we define unfit, the threshold between unfit and fit, as follows. In you or I, if our maximal metabolic rate was less than 10 METs, we would be considered unfit. If it was more, we would be considered fit. And you can see there's a slightly different threshold depending on the age range. That's just because aerobic fitness goes down as you age, and so we have to change it relative to the age group. Now, this study presents data in the same way that we've seen all the other fitness data in the ACLS studies. This is in quintiles, quintile 1, 2, 3, 4, and 5. Here, unfit is the individuals in quintile 1. Fit are the individuals in quintiles 2 through 5. So all of those quintiles are grouped together, and that is the fit group. The unfit is quintile 1. We can't also transfer these thresholds to any of the previous studies just because the sample size is different. It's a different number of people. And so their treadmill test results are going to be different, and the threshold will probably be different as well. So that's why we couldn't bring this up on previous slides, but we can do it now. So what do we observe? Well, a pretty consistent reduction. If you are unfit and you stay unfit, if that's the standard relative risk for premature mortality, then adding fitness improves your situation. If you become more fit, or if you start fit and stay fit, you have progressively reduced risk of dying. Just moving from quintile 1 to quintile 2 confers a 44% decrease in the relative risk of death. That's really potent when you think about it. So, really useful information, encouraging motivational type information for individuals that might already be unfit. They don't have to become athletes. They can just move to the next grouping, move to the next quintile, and have a reduced risk of premature mortality. Now, something stands out to me on this slide that doesn't sit well, and maybe it's not sitting well with you either. We have 4 options here. Individuals that are unfit at baseline and stay unfit. Individuals that become fit. Individuals that were fit to begin with and then detrain, become less fit, and then people that are always fit. It's the third group that I'm curious about. Individuals that start being fit and then become unfit. They have the same lower relative risk of mortality as these other groups, and that doesn't sit well with me. Being fit and then becoming unfit, shouldn't that also increase your relative risk of dying? Why is it? What happens with this group? How can we possibly explain these results? It's difficult to explain these results. One, this is a measure of fitness and not physical activity, so maybe these individuals, even though their fitness is going down, maybe they're still physically active. Maybe. It's hard to wrap your head around because being physically active is what you would do in order to maintain or improve fitness, so it's really hard to reconcile that notion. We don't know when the transition occurred. When did the detraining happen? Maybe these individuals at baseline were already in the process of detraining. Maybe they were on the threshold of being in quintile 1, but they registered in quintile 2, so maybe there's not much of a change in fitness and hence not much of a change in mortality risk. Maybe. Maybe it's just people in quintile 2 that we're observing here. If there's a small change in fitness, kind of like the last point, maybe that means a small change in relative risk. Who knows? Or could it be that it's just that this is the smallest group of all 10,000 individuals? 221 men in this group out of 10,000, which is less than 1%. It's a fifth of 1%. And here only 9 individuals died. So is this the right number to reflect the death rate? Because that's what we base the relative risk on. So it's possible there's error here, and that's what is obscuring the relative risk in this group. Either way, we're not really convinced about these results, and I'll mention this later as well, but another study followed up on this with a different subset of individuals, different group altogether, found that the risk went up in this group. I'm more inclined to believe those, and I think you'll probably agree, but if you don't, that's fine. I'd love to hear your opinion. Now, I brought this slide up to help corroborate the threshold list on the first page of this study. This isn't in the notes that are posted online, but I thought it's really important to know that this trend persists across all age groups. In young, in middle-aged, and in older, a higher level of fitness is related to a reduced rate of all-cause mortality. Now notice this is also a log scale, so it's not linear, which means the gaps are a lot bigger. So the improvements are probably going to be more impressive than they look here. And also notice here that there's no mention of the fit to unfit group. So these authors might not have believed their own data and decided not to include it in this figure. Not sure what to make of that, but there's only the three groups. Number one on the far left, unfit at both time points. Number two, unfit initially and then fit 5 years later. And then the third group, the individuals that were fit the entire time. Still, though, really important to recognize here that there is an improvement regardless of age. So it's never too late to improve fitness and reduce your risk of all-cause mortality. That's a really important message to take out of this. Overall, it seems that there is a pretty wide agreement for fitness in reducing mortality risk. The more fitness you have, the better. If you're fit and you stay fit, you have the least risk of premature mortality. The paper that I just mentioned that contradicts the fit to unfit group in the Blair study that we just looked at is this Paffenbarger study here with the Harvard alumnists. They saw an increase in relative risk almost to baseline levels in the unfit group, which makes a lot more sense and is easier to reconcile. But regardless, more fitness is better. Having a high fitness and then keeping that high fitness seems to give the greatest reduction in mortality risk. We can see that in another study here by Erickson. This is not in your average individual. These are higher fitness, more trained individuals. And at baseline, like in the ACLS study, we have quartiles here instead of quintiles, but quartile 1 is the lowest fitness to begin with. Quartile 4 is the highest along the front. And then the measurements along the side are the change in fitness from baseline to the follow-up period. So all the way in the back, quartile 1 is the least amount of change. Maybe fitness went down, maybe it didn't change. It's the least amount of change. Quartile 2 is second least, and then all the way to quartile 4, which is the biggest improvement in fitness over the follow-up. And you can see that like we would expect, mortality risk is the lowest in the individuals that were the most fit to start with, and that improved their fitness the most over the course of the study. Mortality risk was greatest, or one of the greatest, in individuals that had the lowest fitness and then the least amount of improvement to end with. So nothing new here, just reinforcing the point that more fitness is better. So looking ahead, looking back first before we look ahead, we've realized that not all individuals are healthy, and so we have to be able to apply our results to individuals with chronic disease. In some studies that we used to establish this idea, chronic disease was only mentioned as an exclusion criteria, but in order for us to transfer this information to the greater population, we have to make sure that it applies to individuals with chronic disease, and as we're starting to see, maybe the benefits come from correcting the pathophysiology associated with chronic disease. Maybe the effects are greatest when there's something to correct. And perhaps unsurprisingly, the benefits of improving fitness hold even with multiple various risk factors as shown here. This is a synopsis by Myers in the New England Journal of Medicine that looked at individuals that had a wide variety of risk factors, and you can see across the bottom these risk factors, regardless of what they are, increasing fitness, having a higher baseline fitness in the brown bars over 8 METs is associated with a lower risk of mortality. As fitness decreases, risk of mortality, risk of death goes up. Now, we don't know exactly what pathophysiology is improved, what risk factor is corrected in these cases, just that mortality goes down with higher fitness. And we can also perhaps guess that it's not just the effects of exercise on one risk factor, but maybe exercise affects a lot of different things. It improves a lot of different areas because the trend is the same with such wildly diverse risk factors. Hypertension might not be related to smoking. Not a great example. COPD, chronic obstructive pulmonary disease, might not be related to total cholesterol. Yet there's still the same improvement with increasing fitness. Diabetes might not be related to smoking. In all of these cases, we see that improvement, so exercise is really potent in protecting against premature death. Now, what other health considerations should we take into account here? We've talked a lot about physical activity and cardiorespiratory fitness, but those aren't the be-all, end-all. In fact, it's only one half of the equation if we consider dietary habits. A lot of chronic diseases stem from an energy imbalance, so too much intake and too little output, too much food and too little exercise. So will improving your fitness work similarly if you tend to overeat? And for that matter, people that tend to overeat tend to eat unhealthily. So does exercise confer protective effect if your diet is unhealthy? That's kind of important to figure out because if we're looking to help an individual that's at risk of premature mortality, that might be overweight with a cluster of apparent risk factors, it's likely that they're unfit and they have a poor diet. I'm not going to say that's the rule, but it's likely. And so we want to be able to say that exercise can start to reverse your situation. You don't have to change your exercise habits and your eating habits and everything all at once. That might be too tall an order. So can fitness do that on its own? Why not go back to the ACLS with all of their data? We can look through and looking at the food records, they've developed what they call an unhealthy eating index, which gauges how much of these food products the typical person's diet contains. So red meat, starchy white potato products, non-whole grains, etc., added sugar, things like that. If your diet contains a high degree of these, you'd have a high unhealthy eating index. And they've gathered these individuals into quintiles, much like the fitness quintiles that we see in the ACLS that we know at this point. But they're grouping them into low, medium, and high unhealthy eating index categories. So the low being quintile 1, medium being quintile 2 and 3, and then high being quintile 4 and 5. This is really just to maintain consistency. It's not because it's the right way, it's just because this allows them to relate to their other studies and for us to compare and draw conclusions. In your slides, you'll notice that it says quartiles, mirror of the fitness quartiles, but technically it's quintiles because there are 5 groups that the ACLS breaks their subjects up into. So, what happens? Well, the first thing that we notice is that fitness is still a strong predictor of mortality, perhaps not surprisingly. We have the 3 clusters are high, medium, and low fitness, and as we get towards a lower fitness, the hazard ratio goes up. Risk of premature mortality goes up. Fitness is still a strong predictor of mortality, but the unhealthy eating index is not really a strong predictor of mortality. There's perhaps a modest influence within each cluster of bars, and maybe that's most apparent in the middle series of bars, the moderate cardiorespiratory fitness, where the higher the unhealthy eating index, seemingly the higher the hazard ratio seems to be. But this doesn't hold up with the other 2 sets of bars, so only a modest effect, and we can't say that it's statistically significant. So it seems as though regardless of what your diet is, improving cardiorespiratory fitness can provide some protective effects, can reduce your risk of mortality. What about muscular fitness? We've spent all this time talking about cardiorespiratory fitness, and there seems to be some indication that muscular fitness might relate to improved longevity or a reduction in mortality. We get this from studies in older individuals. Most of this work is done with the focus being mobility or muscle wasting, also called sarcopenia. We see sometimes that these individuals tend to live longer. So is there an effect of resistance exercise on mortality? It makes sense that there might be, because with more muscle mass, you increase your basal metabolic rate. You might need to use more onboard energy to maintain that tissue. It improves insulin sensitivity. It tends to lower resting blood pressure. All these things that are risk factors for all-cause mortality tend to be improved with increased muscle strength. Now, we see this work in older individuals, but what about younger individuals? Maybe there's some protective effect. Does being stronger earlier in life and then staying stronger also confer a protective effect for all-cause mortality? Well, we're not sure. There isn't really an effect for younger individuals, and that's probably just because the rate of mortality is so low in young individuals, individuals less than 60 years old. But there is a really big impact of improving strength in individuals older than 60. As you progress here, they've grouped these individuals into thirds of strength, lowest, middle, and upper third of muscle strength. As you increase muscle strength, it confers, or it is associated with, a reduction in all-cause mortality. So at least for older individuals, this effect seems to exist. We can also see in this study kind of an interesting finding that there seems to be a reduced mortality in healthy weight adults. Regardless of age, being stronger seems to reduce mortality risk in healthy weight adults, those with a BMI between 18.5 and 24.9. Over a BMI of 25, what we considered we still do consider this overweight. There is an abrupt decrease as you move from lower to middle, but then not much more improvement as you increase strength further. This is a little bit difficult to interpret, though, because some of these individuals, though we consider them overweight, might not be overweight. Individuals with a large amount of muscle mass simply pack more mass onto their frame and have a higher BMI, so it's unclear at this point how those individuals skew the results. Difficult to draw too many conclusions, but there seems to be some benefits to increasing muscle strength. Those benefits simply are that there's a large reduction in mortality in older adults, so strength training seems to be really good for older adults, and there's progressive improvements with muscular strength in healthy weight adults regardless of age, but there's an improvement with being overweight, but only when moving to a moderate level of strength, a middle third. What can we summarize? What main points can we distill out of this lecture? I think first and foremost, fitness is good. Activity is good. Regular physical activity and high cardiorespiratory fitness are associated with a reduced all-cause mortality rate. Not only are they associated, but improving your fitness status tends to decrease your risk of all-cause mortality. Fitness is good. This trend isn't only evident in men, it's evident in both men and women. It's evident in young and old men and women, so a wide variety of individuals. It's almost applicable to anybody in the population. And though there was initially some controversy that physical activity wasn't the most powerful protector when it came to healthy asymptomatic individuals, for individuals that are at risk of or that have chronic disease, just physical activity does seem to have its own protective effects. Of course, improving fitness also really good in these individuals. does confer some protective benefits, but physical activity itself is good here as well. And more is better. There's a dose response where the more physical activity you do, the greater the protection, and the higher your fitness level, the greater the protection. Higher fitness and keeping higher fitness, improving higher fitness seems to confer the biggest protection against all-cause mortality. Not messages that should really be too confusing. They're common sense, and we might have even known this before getting into this lecture. But what I'm hoping this lecture did is help uncover why we know these, or how we know these. Where did this work come from a historical perspective? Hopefully I was able to achieve that, at least in part, through this lecture today. So if you have any questions, don't hesitate to email or stop by my office. Otherwise, I will see you in class.